session. We are having a pathology session today, and where we had initially thought that we'd be looking at masqueraders of fatty liver disease, we had a bit of trouble with the NHS system being hacked, and Prof. Hale has gladly come to the rescue with another form of masquerader, this time regarding plasma cells masquerading as other, plasma cells by neutrophils that would be more associated with an autoimmune picture, and looking at their other varied presentations. So over to you, Prof.
Okay, so thanks, Bilal. So yeah, sorry about the mix-up in the title of the talk. As Bilal said, we've got a problem with retrieving cases from the NHS records because as you know, as most of you know, the NHS system is been down now for 3 weeks. So what I thought we'd do is take a couple of cases where plasma cells are present in the pathology, and also neutrophils that are present in the pathology. And this is not an uncommon thing for us as histopathologists to try and sort out. And oftentimes, in fact, one thinks, oh, well, you just look at it and you make the diagnosis. In fact, that's not the situation. So the first patient, Bilal, I thought we'd do is your patient, AR. I don't know if you've got his history readily to hand. I can also do it from what I've got on the report that I did for you.
Yeah. So Mr. AR is a gentleman in his 50s that presented with quite a significant hepatitis. He had a biopsy elsewhere, as well as an initial workup that was somewhat suggestive of an autoimmune picture with with a mildly elevated IgG, less than 1.5 times upper limit of normal. He had a positive ANA at 1 in 80, positive liver cytosol, and had a liver biopsy done. The liver biopsy noted the presence of a lymphoplasmacytic infiltrate with an interface hepatitis, and the initial impression was that, okay, this is probably an autoimmune hepatitis. We treated him with some steroid, and he had an initial response. His transaminases were elevated at the start, just under 1,000, and they gradually improved, such that on discharge, after about 5-6 days of steroid therapy, they were sitting just under 200. He went home, and on oral steroids, at a slightly reduced dose than what he was on in the ward. And when he did a repeat blood test a week later, the enzymes had jumped up significantly once more. There was a degree of doubt in my mind, because his repeat ANA with us was now negative. His IgG was, somewhat marginal. So I was concerned about whether or not I had the right diagnosis, and whether or not there was any confounding factors. Full viral and extended viral workup was then negative, and interestingly, an IgG4 was picked up as being twice upper limit of normal. So with all of this information, we repeated a biopsy. Sorry, I should add his MRCP liver was normal, and there was no pancreatic disease. Sonar of his parotid glands was normal, and he had just occasional mild dry eyes. So over to you, Prof.
Okay, so thanks, Bilal. So these cases, I think, can be quite tricky to interpret. I'm not always sure that we get it right all the time. And I think this is a case in point, and Bilal will give us some more history, I think, as the case unfolds. So what we've got then is a liver biopsy, which I think is a transjugular biopsy, which is why it shows a little bit of fragmentation. And this is the second biopsy. We did not actually see in our department the original biopsy. But I think if we look at this biopsy, as I said, it's unfortunately it is a little bit fragmented, which is procedure related. But nevertheless, I think one can appreciate that we can probably have a fairly good interpretation of the changes. So this is what it looks like. I'll show you the H&E first. Just run down it, and then if we look at the reticulin stain of that particular core, we can see that there is certainly some disorder, and we'll go into this in more detail. I'll just make this field a bit bigger. So you've got some disorder to the reticulin pattern. You can see, for example, here that we've got expansion of the fibers, at least of the portal tracts. And then if we look at the serous red, the same sort of picture comes through. Serous red is a very good stain for picking up collagen. It's actually a lot better than the Masson trichrome, and which is the sort of used to be the original yardstick by which collagen was assessed in the liver. But you can see that there's a fair bit of fibrosis in this liver. Okay, so we'll look at this in more detail. I just want to share that's it. That's fine. Okay, so now we're going to go back to this H&E. So you've got an idea that we certainly got evidence of chronicity in this liver. So when we look at the portal tracts, we can see that they are expanded. And the first thing that happens is Bilal gives us good histories, and with that sort of picture that he's just outlined, the thought of autoimmune hepatitis obviously is uppermost in one's mind. But then when we actually have a look at these portal tracts, we can see, in fact, that the first thing that actually happens is that neutrophils come to mind. And if we look at these here, we can see that these are all neutrophils. And then the alarm bells start to sound, because suddenly what's happening is that the pathology doesn't seem to match the clinical history. And I think that's a very important lesson that one has to understand, certainly from a histopathology point of view. If things don't match, then you need to think again or ask additional questions. If I go up to this particular portal tract there, you can see that we've got a bit of bile ductular proliferation, for example, and we've also got this neutrophil inflammatory infiltrate. And in fact, in some instances, I think that's a neutrophil which is infiltrating into a bile ductule there. And then we've also got plasma cells. So now the picture starts to become a little bit more confusing, because not only do we have neutrophils and bile ductular proliferation, but we've also got plasma cells. So the plasma cells are there. There's also plasma cell clustering. And here we've got a group of plasma cells, there's 3 of them in there, and they're associated with this interface inflammatory activity. And when you see plasma cells with interface inflammatory activity, we have to think of autoimmune hepatitis. So from that point of view, if the patient is starting, or the histology is starting to match the history. But then we look at this sort of area here, and you can see that not only do we have this interface inflammatory activity with plasma cells that I've already shown you, but we also have interface inflammatory activity comprising neutrophils. And in fact, there is indeed some microsatellitosis of hepatocytes by neutrophils. Now, that certainly is an unusual finding with autoimmune hepatitis. And in fact, there's another good example there of satellitosis by neutrophils of that hepatocyte. So there are a couple of rules, if you like, that we think of. Neutrophils, as we know, are an unusual finding in patients with chronic hepatitis. So if we see neutrophils in a liver biopsy, there are basically three groups of things that we need to think about. The first is ethanol use. The second is bile duct obstruction, cholangitis, and the third is drugs. And ethanol, as you know, causes an alcoholic hepatitis, neutrophil mediated, and one of the important drugs that mimics that picture is amiodarone and its various analogs. And in fact, often, and we've all been through this, often we see patients that look as though their liver biopsies show an ethanol type of picture. The patient actually denies the use of ethanol, and in fact, then you ask the questions: has this patient, or is this patient taking amiodarone or an analog? And sometimes, in fact, you get the history, certainly as has happened to myself on a couple of occasions, where there is no history of amiodarone. And often, in fact, what happens is some of these patients actually forget that they're actually taking that particular drug. So one has to be very persistent in looking and searching for that clinical history. So in this particular instance, we have a situation where we've got a liver biopsy, which is showing plasma cells and neutrophils. So what do we do next? Well, the next thing, obviously, is to try and go through the rest of the biopsy and decide, in fact, whether there are any other stigmata of ethanol. And the things that we would look for would be steatosis and, of course, Mallory-Denk bodies. And if we look through this biopsy, in fact, there are neither of those. All we've got is, once again, another portal tract, and you can see lots of neutrophils associated with this ductular proliferation. There is a little bit of, I suppose one could call it ballooning of the hepatocytes, but in many instances, in fact, there is no steatosis, and Mallory-Denk bodies are not visible. So to call this ethanol is a little bit of a long shot, because we don't really have much in the way of supporting information. And Bilal, in fact, hasn't given us that information as to whether this patient consumes ethanol or not. So we've got a situation now where we've got a liver biopsy, which is showing evidence of chronic disease. We've got expansion of the portal tracts. We've got a mixed cellular infiltrate comprising plasma cells and neutrophils. And somehow we've got to find out why we have these neutrophils. So before we phone Bilal, which is what we do on a daily basis, we look at the Sirius red. And in fact, let me look at the retic first. And when we look at the reticulum, we can see that we've got this expansion, as you see there, of the portal tracts. So you can see this a fair degree of significant liver injury here. We've also got some regeneration, which is happening. So this is not an acute process. But we know he's certainly got the serological features, some of them anyway, of autoimmune hepatitis. So I suppose one could ascribe the expansion of these portal tracts and the regeneration to autoimmune disease. There's another focus there of hepatocyte twinning as well. So when we go to the Sirius red, what we've got now is some more information. So here you can see the fibrosis and the expansion. That's a portal tract down there. You can see the bile duct, and you've got this expansion by fibrosis. You've got sinusoidal fibrosis, which is extending into zone 1. And in this area here, we're starting to see a little bit more diffuse fibrosis, and we're starting to see a chicken wire type of appearance. Now, that's unusual for autoimmune hepatitis. That is the chicken wiring. And when we look there, I think that that is a central vein here. So you've got perivenular fibrosis, and we've got some chicken wiring again, with extension of the sinusoidal fibrosis into zone 3, and I think it's even going through into zone 2, and maybe meeting up with that area there, which is, that's a portal tract there. So now one has to say to ourselves, could this be alcohol or could it be drugs, such as amiodarone? The patient is 53. He's of an age where he could be on medications such as amiodarone. And then we look down here and we can see once again this chicken wiring that's now starting to become quite apparent. So the telephone goes. History, very important. Communication with the physicians and anyone who's sending in the biopsy to try and glean additional information. So I suggested to Bilal that, or I asked him, I think that there certainly could be an autoimmune component to this. It would fit with the serology. But as I said to him, the neutrophils, we've got to find a reason for the neutrophils. Is this alcohol or is it drugs? So Bilal, do you want to let us know what you found?
I'm sorry, just trying to unmute. So he is an otherwise healthy individual, not on any real chronic medication. Once he knew he had a bit of a liver problem, he started himself on some milk thistle. Alcohol-wise, he has at least 2 binges per week, and that's defined by him taking at least 6 beers plus additional shooters when he goes to play golf with his friends on a Saturday. So we did manage to elicit that history of binge drinking.
Thanks, Bilal. So it looks then as though this indeed, in fact, is showing 2 pathologies. The first is autoimmune hepatitis, and the second is chronic ethanol use. What is interesting about this is that we don't have we don't have any steatosis. And that, I think, could probably be explained by the fact that he's being investigated now for about 6 weeks, I think it is, isn't it, Bilal? So the fat could have gone. We don't have any Mallory-Denk bodies, but I think the chicken wire fibrosis is a lasting telltale sign that this could be secondary to ethanol. I think the other thing that's also interesting about this is that, as Bilal mentioned, he also had a history of hepatitis A infection back, I think, in about 2000, about 20 years ago. Be interesting to hear anyone's comments about the hypothesis that that infection by hepatitis A may lead on to progression to autoimmune hepatitis in subsequent years. So I leave you then with this case, and I will refer to this case with the next biopsy as well and show you a few, I think, important differences. So I think there are a few subtle features here that then support a diagnosis of autoimmune hepatitis. I think it has been modified to a certain extent by the previous steroid therapy. We haven't reviewed the previous biopsy. That's something that we probably need to have a look at to assess the intensity of the plasma cell infiltrate. But interestingly enough, neutrophils were also reported in that particular biopsy. So looks like it's autoimmune hepatitis with ethanol-induced liver injury as well. And we're now starting to use the SALV score. Given the history, we called this a SALV grade of S0 because there was no evidence of steatosis. A2, activity of 2, because there were neutrophils readily identified, but no Mallory-Denk bodies or ballooning, and there was no evidence of cholestasis. And then stage we gave it SFS3P, based on the pattern of fibrosis, and the P referring to the pericellular fibrosis. Thanks, Bilal.
Yeah, thanks, Prof. Certainly is one of those cases where, once again, certain things that occur commonly can also occur in conjunction with some, your rarer conditions. So, where both NASH and alcohol-related liver disease are fairly commonplace. These individuals could still have other hepatic diagnoses, viral hepatitis B, C, or even an autoimmune hepatitis. So just to be aware of.
Yeah, thanks, Bilal. I don't know if anybody's got any questions.
If I could make a comment,
yeah.
Sorry, Bilal
Yeah,
and Martin, you mentioned when the pathology doesn't fit in with the clinical presentation, it's important to pick up the phone, but there is a tendency to go from clinical presentation to imaging to pathology. And I find the simple liver-associated enzymes or liver function test panel very important in differentiating the nuances that, for example, you pick up on pathology that don't fit with the clinical presentation. It's just another easily available investigation which might assist you in differentiating or looking for something that you haven't picked up clinically that the pathology presents. So I use liver-associated enzymes routinely. In fact, I anchor my diagnosis on that and try and make sure that the pathology fits in.
Yeah, thanks, Chris. I mean, that's a good observation. In fact, and I do, things that are very similar. I never look at a biopsy without the enzymes. And in fact, I've expanded that now. I try and make sure that I get all the information that is available from all the labs, because it is surprising what we all forget. You sort of suddenly forget that there's been an ESR of greater than 100, for example, 6 months ago, which people forget. And in fact, this particular patient illustrates that well, because one looks at this, and what we saw was that his IgA was 8.4. Now, one could argue that that's up because of the autoimmune hepatitis. His IgG was 17, so it's up a little bit. But his IgA, which don't know what you people think, but that's a fairly good marker, I think, of ethanol.
Mm.
And the other thing was that his MCV was also varied. It did vary. In some labs it was over 100. So
Okay.
with a macrocytosis and an elevated IgA, and the other thing as well was he didn't have exact reversal of his AST-ALT ratio. So the enzymes I saw were an ALT of 612 and an AST of 748. Bearing in mind, that to me those are all subtle pictures, at least subtle pointers towards alcohol.
Sure.
But the problem comes, and say, well, he's a social drinker, or they're a social drinker. How do we define a social drinker? Wayne's got a question.
Well, in my patients, they're social drinkers, but they're not drinkers because they drink when they eat. So they're not actually drinking, they're eating.
Dr. Simmons has got a question.
Good afternoon, everyone, and thank you, Bilal, and thank you, Prof. Hale, for a great presentation there. My question is about the alcohol again. We're often faced with a patient where we get the suggestive history. He comes in with the alcohol, with the hepatitis, the serology is low positive anti-smooth muscle. There may be some other factors where you're thinking, could this be viral, or this history of, viremia or viral illness? And then, we get this convincing history of alcohol intake in the prior few months.
Wayne, I think we've just missed you.
We've lost him, yeah.
Well, so if I can kind of guess where he's going towards, one of the things that would be great for us to have available would be phosphatidal ethanol testing.
Can you hear me now, Bilal?
There we go, yeah.
Yes.
Go on, Wayne.
So my question went about, that patient where you get the convincing history. We often tell them, let's do a 6-week period or a 4-week period of abstinence. And if the counts come down with the suggestive transaminases, the AST-ALT reversal getting improved, the GGT coming down, we label that then.
Oh, we lost him again.
No. Let me just give him a second. Hopefully he comes back.
Hello?
Yeah, you're back. You label him as?
Yeah. So can we, after that 6-week period, if the picture improves, then obviously, you take it as alcohol. But if the picture does not improve and then you proceed to biopsy, will that period be enough to say that alcohol won't cloud your biopsy then in looking at these other possibilities?
I think it'll be cleared that quickly. I mean, these changes, your necroinflammation can still take months to settle. Yes, alcohol's one of those that will still settle somewhat quickly. But if you look at your patients, with significant decompensation, I find that the majority of them improve over a period of about 6 months, and then continue improving up to 18 months after. And I think that some of the residual changes are still going to be there on biopsy. If you look at some of our patients that then subsequently still go on to transplant, and this is with a definitive 6-month sobriety period, the diagnosis of alcohol-related liver disease is still able to be made, especially in terms of the fibrosis pattern. But I think more for Prof, maybe you comment on the actual pathology side.
Yeah, so Bilal and Wayne, yeah, I think as Bilal says, that the stigmata of ethanol will remain for quite some time. I think the fat may disappear, but the neutrophil infiltrate and that fibrosis is unlikely. Yeah, and as Bilal said, we've seen patients where, I mean, I can remember a couple of patients where we've almost been convinced that they have been drinking right up to the time of transplantation, because the biopsies or the explants have been full of Mallory bodies and neutrophils and that sort of thing. So I think it varies from patient to patient, but the fibrosis, the pericellular fibrosis, is certainly going to remain. I think your question about the autoimmune or the immune side of it is an interesting one, because of the relationship between steatosis, or the increasing relationship between steatosis and immunoglobulins and the autoimmune markers. That seems to be coming out in the literature more and more. Almost a sort of a pseudo autoimmune picture, if you like, in inverted commas. I don't know what you guys as physicians would say.
I think any form of chronic inflammatory process is going to result in some degree of low titer positive autoimmunity. You look at your NASH patients, a lot of them are 1 in 40 smooth muscle positive. that doesn't make them an autoimmune hepatitis. So your globulins are elevated in periods of inflammation secondary to inflammation, which is a process of immune activation. So I think we can't be too surprised that they're up. I think the degree of elevation and the degree of autoimmune positivity is where we still need to take into cognizance.
Yeah, and I think, Wayne, if I could just probably say, I mean, I know it's speaking from a histopathology point of view, but you can never have too much information. And if I know that obviously risks associated with liver biopsy, but if a liver biopsy can be done safely, and I think and the enzymes remain elevated, and there appears to be continuing liver dysfunction, then I would suggest that a biopsy be done. But obviously you've got to weigh that up with the risk.
I see Mzama is on the chat, maybe to invite input from Mzama.
Hi, Bilal. Yeah, thanks for the invite to contribute. Just the one thing I'd add is the role of metabolites. I think you might have just mentioned that your ETGs, ETSs, yeah, and that seems to be something that kind of is able to tease out these cases, at least with our side, and particularly when it comes to the transplant space. Is this patient truly abstinent? Is this patient, are there other, compelling factors? Just a quick ETG on the urine or in their blood and hair as well. You can check metabolites in that as well, and that really does help in terms of diagnosing
which are you guys using in your day-to-day practice?
In clinical practice, urine ETGs. So the urinary metabolites, but then in trials we can use anything, depending on whatever trial is running and what they're testing. But yeah, from a clinical practice perspective, urinary metabolites.
Okay, so phosphatidal, your phosphatidal ethanol markers are, I think, internationally gaining quite a bit of traction. It's kind of like your HbA1c of ethanol consumption. Those markers last about 3 months and will give you an idea of what sort of consumption the patient is taking in. It's a blood test, not readily available at the moment because I think there are, not sure really in terms of the medical implications. I think providers are a little hesitant to be ordering these sort of tests in private due to various funder issues and getting funders hassling about payments, which can be an issue. But certainly it is one of the markers that I've been pushing to try and come in. Okay, shall we go into our next case?
Yeah, next case, Bilal, is LN, Dylan's patient.
Prof, I know we just discussed the patient recently, but okay, yeah. I've got broad brushstrokes.
Yeah, so she is, I think, a 33-year-old woman who was known to have autoimmune hepatitis. So let me just get the notes here. I just find it. So she,
From what I recall, she's a 33-year-old lady that was
yeah,
initially diagnosed as an autoimmune hepatitis based on fairly convincing serological and autoimmune markers. She was placed on prednisone and subsequently azathioprine as per standard practice, and then unfortunately developed a pancreatitis.
yeah,
She was also on Bactrim at that
that's right.
stage due to the prednisone use. So everything sounding, you know, quite well thought out and well done. But she still flared with this pancreatitis, which sounded like it was quite significant. I think she also developed some form of cytopenia on the azathioprine, so that was
Also,
pulled
she
off.
developed PCP.
Pneumocystis pneumonia then, despite the Bactrim prophylaxis. Some question marks around that diagnosis. It was based on a PCR, and whether or not it was a bit of ARDS associated with the pancreatitis is the question. There was no CT chest, just based on X-ray oxygenation and PCP PCR being positive.
Right. So she had an IgG. Now, bearing in mind that she had been on steroid therapy, so she had an IgG of 8. IgA was normal. IgM was normal. Pancreatic enzymes were slightly up. The anti-smooth muscle was negative. LKM, LC was negative. SLA was high positive. PBC markers all negative, and the ANA was negative. At the time of the biopsy, her total bilirubin was 37, with a direct component of 24. The ALP was 169, gamma was 839, ALT was 102, and the AST was 56. She also had a platelet count of 150 and borderline splenomegaly. So she was referred because of this pancreatitis. And I thought it was a good case to show you in respect of the previous biopsy. So if we take the let's take the H&E again. Right, so this is the H&E. And as we just go quickly down the biopsy, you can see that we get to portal tracts, which show significant expansion. There's something happening there. There's this fibrous connective tissue band that's coursing across that. That's a portal tract, and you can see the blueness of inflammatory infiltrate. And then we've got another portal tract there, once again, blueness showing the inflammatory infiltrate. If we look at the retic, the architecture of the liver, a little bit nodular. There is some regeneration, for example, going on here. You can see that there's twinning of the hepatocyte plates. And again, a bit more nodularity there. Certainly not cirrhotic. And then we've got this broad expanse of fibrous tissue with a portal tract. There's that fibrous connective tissue band that's coursing through the biopsy. And then another portal tract there, which shows a thick expansion and septum formation. And then another fibrous tissue band there. So we've certainly got F2 fibrosis in this biopsy. Whereas I think we've got F2 fibrosis. If we look at the reticulum condensation, doesn't always equate to fibrous tissue. But if we look here, we can see that that's expanded there. We've got that there, and we've got that there, and that's that portal tract, which you could see the septum formation. So this is certainly F2. There's no evidence of any architectural distortion. So that gives us an idea as to where we're headed with this particular biopsy. So now, when we look at the cellular infiltrate, if we, for example, look at this area here, we can see that we've got hepatic arteriole, the vein, portal vein, bile ducts there. And what we're interested in is the cellular infiltrate. And when we look at the cellular infiltrate, we can see that there are, once again, significant numbers of plasma cells. So you've got plasma cells there, got a plasma cell there as well. And when we look at this in this area here, this is primarily lymphocytic and plasma cell based, a little bit of clustering of plasma cells as well, for example. If we look down here, this is a cluster of about 4 or 5 plasma cells together. So that's on that side of the portal tract. But when we move across to this side of the portal tract, we start to see that there's some more cells that are coming into play. And those cells are our neutrophils. And that is a bit confusing, as we said earlier in the previous biopsy. And here you can see we've got neutrophils there, and they're starting to participate in a bit of interface inflammatory activity. If we move to this area here, we can see that once again, in this part of the portal tract, we can see that we've got plasma cells. They're very closely associated with the interface area. And I think that we could certainly say that we've got a group of 3 plasma cells there that are showing a bit of interface inflammatory activity. And that's always a very concerning picture for autoimmune hepatitis. If we look at this here, we can see that there's a plasma cell there that is sitting right in the right within and amongst the hepatocytes. When we move to this part of the biopsy, though, what we see now is a slightly different picture. We see bile ductular proliferation, and we've got neutrophils. So we've got ductular proliferation plus neutrophils, and then we go through that same diagnostic algorithm, if you like, that I alluded to in the first biopsy. Could this be ethanol? Could this be a large tract obstruction? Could this be drug-induced? And when we look at the rest of the tissue, the parenchyma, you can see there's a little bit of steatosis, large droplet steatosis, but there's no evidence of steatohepatitis or ballooning degeneration. But what is apparent, in fact, is this here. And you can see that we've got multiple canaliculi. This is one canaliculus here, which has got quite a significant bile plug in it. And then we've got another canaliculus over here with another bile plug in it. So putting that combination together of the bile ductular proliferation plus the neutrophils plus the bile plugs, what we're dealing with then, of course, and the plasma cell infiltrate, what we're dealing with is a combination of autoimmune hepatitis. But this is not alcohol. This, in fact, is obstruction, large duct obstruction, secondary to chronic pancreatitis. And then before I show you the Sirius red, I just wanted to show you this this focus here, which is a unusual, or not unusual, it's difficult to find, but this is a focus of what we call imperipolesis. And this is a hepatocyte nucleus there. And then that's a lymphocyte, which is being phagocytosed by that hepatocyte. And this is said to be one of the sort of diagnostic features of autoimmune hepatitis. And there's a plasma cell there in this interface zone. So that's the morphology. And then when we look at the Sirius red, so remember last time we saw the chicken wiring, okay? And alcohol, obviously, because we're seeing neutrophils, has to fit into that differential diagnosis, or has to be, sorry, not fitted in, but included in the differential diagnosis. Whereas if you look at this particular Sirius red here, you can see, for example, that this there's a little bit of feathery change, if you like, but a sinusoidal fibrosis in zone 1 adjacent to this portal tract, but we're actually lacking the pericellular fibrosis that is characteristic of ethanol. So I put it to you that what we're seeing here is autoimmune hepatitis together with superimposed common bile duct obstruction secondary to chronic pancreatitis. And I think the comparison in the two biopsies is interesting because both biopsies show plasma cells, both biopsies show neutrophils, but the etiology of the neutrophil infiltrate is different, and that really is sorted out, interestingly enough, on one stain, and that's the serious red stain. So I thought an interesting case, Bilal. Thanks.
Yeah, absolutely. Thanks, Prof, for contrasting those two cases. Opening up to any questions from anybody? Anyone just put your hand up? Doesn't look like it, Prof.
Okay. So
we've got 10 minutes for a final case. Maybe if we
I could do another final case. So this is really what's just going across my desk at the moment, or underneath my microscope, I should say. And this is a patient, not an adult. This is a child, an 11-year-old child. And she was admitted in acute liver failure, underwent transplantation a couple of weeks ago. And this is the histology of the explant. And I thought I'd just share this with you because we don't often see it, probably 2 or 3 times a year, maybe less. So what we've got is a very busy looking liver. And you can see, in fact, that there's extensive loss of hepatic parenchyma. So here we've got these foci of hepatocytes, another focus of hepatocytes there. This is a portal tract here. You can see there's quite significant bile ductular proliferation, and then the intervening parenchyma has completely disappeared. No hepatocytes left in some areas. So you've got confluent necrosis. And if we look at the inflammatory infiltrate, we've got lots of lymphocytes. We've got histiocytes. And we've got lots of plasma cells. So there is a cluster of plasma cells. That's a bit dark. That's a big plasma cell. Those are all plasma cells. Let's see if those show up a bit better. These are plasma cells there, 3 or 4 of them together. Here we are. Here's a whole group of plasma cells there. Can we see these? Let's have a look. So here we are. Those are plasma cells there. Look at all these. Whole cluster of plasma cells. So the differential diagnosis here basically amounts to 2 diseases. The first is autoimmune hepatitis. She is 11 years of age. We have seen patients with acute fulminant hepatitis secondary to autoimmune hepatitis. And the second one is hepatitis A, acute fulminant hepatitis A infection. And that's in fact what this is. So this is submassive necrosis secondary to fulminant hepatitis A infection. And absolutely classic. And I thought I would show it to you. If we look at the reticulin stain, Sorry, wrong one. So I just picked up this area here to show you two things. First of all, this is a central vein there, and that's a portal tract there. And what we've got is, the first thing is that we've got preservation of the reticulum. And you can see, in fact, if you compare the reticulum there, which is being held apart. So remember that the reticulum acts as a scaffold for the hepatocytes. So the hepatocytes remain viable, consequently they are holding the reticulum apart. But when we get to this area here, which is in zone 1 and zone 2, you've actually got a collapse of the reticulum because the hepatocytes have died. And it's very much like taking an ordinary common or garden sponge. When you squash it, you squeeze the air out. And when you release it, the air comes back in and the sponge returns to normal. Now, if this patient were to survive the insult, in other words, the liver would regenerate, then in fact the hepatocytes would then grow back along the reticulum framework. And if you were to biopsy in a year or two, the liver would be completely normal. And then what we've got is the serous red. There's a little bit of fibrosis that's starting to creep alongside of it. A bit of fibrosis is starting to creep into the explanted liver. And you can see the sinusoidal fibrosis. It's a moot point as to whether that fibrous tissue would resorb or not with recovery of the patient. And then the other thing that I also wanted to demonstrate to you was the zonal survivability, if you like, of the hepatocytes. So often what happens with hepatitis A infection, and this is a fairly good area here, you can see that that's a central vein there. This is a portal tract here. Excuse me, and what we've got is you can see that you've got hepatocytes that are surviving in the central lobular region, and they are dying or have died in zone 1 around the portal tract. And then lastly, just to demonstrate to you, and back to the HME, that when the liver regenerates, what happens is you get bile ductular proliferation, and the hepatocytes then act as the stem cells. And so, for example, here, so that's a portal tract. You can see the artery. And then here you've got proliferating bile duct. And you can see that that duct is gradually giving way to the production of new hepatocytes. So this is how the liver regenerates from the biliary epithelium. So 3 cases of plasma cells. Yeah, interesting cases, and thanks. And thanks for
thank you, Prof.
to show you the cases.
Opening up once again for any questions. Any comments? There's a really great, yeah, sure, go for it.
Hi, Bilal. Sorry, Prof, I just wanted to ask, the hepatitis A features on this explant, I'm sorry if I missed it. Were they more or less prominent? And the reason I'm asking is that, is it common for you to present with fulminant hepatitis A as in pediatrics? I thought typically it would be more mild or asymptomatic disease with the peds, and then obviously if coming from a non-endemic area, then you present more fulminant later in life. So I just, if you could comment on the hep A feature specifically here, and was it maybe not the autoimmune that was driving the liver failure, and then the hep A might have just precipitated? Thank you.
Yeah, it's a good point, Zamo. So the first is that there was Hep A proven. So I don't have all the information about the immunology, but what you do raise is the fact the relationship between the immune dysregulation that occurs in hepatitis A. That's well known. In fact, sometimes, excuse me, it is difficult to separate out whether indeed it is de novo autoimmune hepatitis and Hep A. But we certainly see a number of patients every year, pediatric patients every year, that undergo transplantation because of fulminant hepatitis A. And you're right in that it is typically a milder disease, or asymptomatic, in fact, in children. And in adults, it's a much more severe disease. So an adult with hepatitis A is a potentially life-threatening condition, whereas in pediatrics, that's not necessarily the case. But notwithstanding that, we still see every year patients with fulminant Hep A and high viral loads. Yeah.
It's about that like 1 to 2% that'll present with the fulminant liver failure with the Hep A in the pediatric cohort.
But it is interesting, this relationship between Hep A and autoimmune disease.
Anybody else?
I'm sorry, Mzamo, just to say the plasma cells are a feature of Hep A.
Yeah, interesting. Thanks, Prof.
Pleasure.
Okay. We're a minute past 12:30. I'd like to thank everyone who contributed to this, most notably Prof Hale for pulling out these slides, and all the teaching that we get. Very, very grateful to him for that. It's fantastic to look at the pathology, as well as the patient. To everyone who contributed, Wayne, Mzamo, Chris, to the discussion, thank you very much. And then to everybody else for joining us. I hope you found this session helpful. Thank you to the iEcho University of New Mexico and iEcho India team. A reminder that these recordings are available on the Gastro Foundation website. And of course, thank you to the Gastro Foundation. Next week, we'll be looking at upper endoscopy, so be sure to tune in at 5:30 on next week, Wednesday. 4:30, sorry. It's 5:30 now. You'll miss it if you turn in at 5:30. So make sure it's 4:30.
South African time.
So, thanks for that correction. Thanks again, everybody, and see you soon.
Thank you very much.
Thanks, Martin.
Pleasure. Thanks for having me.
Cheers.
Cheers.
Bye.